Ladies and gentlemen, please welcome Dr. Toshevsky.
Good morning, and glad to see that you all made it back from the tables. So welcome to our general session about global access to health care. In keeping with the international theme of this meeting, this forum will delve deeper into obstacles and opportunities in different countries regarding this. But first, let's start with another item. In March of this year, Japan was struck, as you know, by an 8.9 magnitude earthquake, one of the 5 most powerful earthquakes ever recorded on the planet. It was followed by tsunami waves of up to 133 feet, which traveled 6 miles inland, and that's hard for me to fathom as a native of a coastal city. Meltdowns at the Fukushima nuclear power plant added an unimaginable element of damage and devastation. American and international organizations mobilized to send funds and assistance to areas that were most in need. ASCP supported our members' desires to contribute to the immediate relief needs, but we also wanted to do something to help our professional colleagues in Japan. We reached out to the American Society of Clinical Laboratory Science and decided together to create a fund to support the rebuilding of medical technology schools most affected by the tragedy. Karen Brown is here representing ASCLS. Ms. Brown is also a member of the ASCP Board of Certification, Board of Governors. Would Ms. Brown and Dr. Hideo Sakamoto please come forward?
And good morning. On behalf of ASCP and ASCLS, I am pleased to announce that the ASCP-ASCLS Japan Relief Fund raised $10,500 for the Japanese Association of Medical Technology Education. ASCP's International Ambassador Dr. Hideo Sakamoto, chair of the Medical Technology Program at Kobe Tokiwa University, was instrumental in determining the appropriate distribution of the funds. Dr. Sakamoto, would you like to say a few words?
Good morning. Thank you very much. So, I have a letter from the President of Japanese Medical Technology Education, Dr. Mimura. So I'm read on behalf of him. Dear Dr. Tomaszewski, thank you very much for the donation from ASCP ASCLS Japan Fund. The Great East Japan earthquake on March 11, 2011 had been an unprecedented disaster on eastern part of Japan. The current known death toll is 16,000 and nearly 3,800 are missing. Especially, the tsunami was the cause of more than 90% of all deaths. There are 12,000 students aiming to become a medical technologist in Japan. Fortunately, no one lost their life. However, many of them lost their parents or families and their house demolished. In fact, there are students unable to pay the tuition fee. We are trying to find out a way to prevent students from withdrawing in the middle of their student life. It was the moment we received a warm support from ASCP ASCLS Japan Relief Fund. We would like to use the part of donation as a fund to support those students who are in need to pay a tuition. We will never forget warm support from United States. I express my gratitude on the behalf of all of medical technology educational institution teachers. Thank you very much. The President, Japanese Association, Medical Technology Education. Thank you very much. Thank you.
Dr. Sakamoto. Thank you, Dr. Sakamoto. We wish you the very best for recovery in your country, and we stand ready to help you in the future. So thank you.
Hello. My name is Tamika Felder. I'm a 10-year cervical cancer survivor. I want to share a bit about my journey the last 10 years. I was diagnosed in 2001 when, among the general population, cervical cancer was a topic that was not discussed. I was not familiar with cervical cancer. I didn't know about the human papillomavirus, and I was a scared 25-year-old losing her womb to a disease that I now know is preventable. I grew up in an idyllic place in South Carolina, in the low country of South Carolina, with water and beaches, and a home that if there was anything ever wrong, I didn't know. My parents worked hard. They wanted me and my sister and brother to have the best life, and they made sure that I did. I graduated from college and left the security of my family and their insurance and moved to the Washington, D.C. area. I graduated from college and I thought, I'm going to get this job right out the gate making all of this money. You know, that's what happens when you graduate. That didn't happen for me. I got this wonderful job, but that job did not include health benefits at all. I didn't think as a 20-something-year-old not to take the job. This was a dream job. So I took the job. And I wasn't thinking that I really needed my health insurance. And I know you're probably thinking, why would you think that? But as a young woman, I really didn't think that it mattered. I didn't think my health insurance would be so important to me. Fast forward a bit, I get an abscess under my arm. I go to an emergency room. The doctor's treating this abscess, and that doctor asked me one simple question. When was your last physical? When was your Pap test? I had to think about it. And I said, oh, about 3 years ago. That doctor saved my life with that one question. Luckily, I had started a new job, and I had medical benefits, but I didn't have a doctor. So that doctor in the emergency care room referred me to a doctor. I went to go see that doctor, thinking that I would get my clean bill of health, because here I am, this young woman, 25 years old. I've never had a broken bone. The worst thing that's ever happened to me is I got a splinter that was really bad one time, and I'm a drama queen, so when I mean really bad, like I just screamed the whole time while taking it out. But I've never had any major medical issues. I go to this doctor, and because she doesn't have my family history, she is just very, you have to come back in 2 weeks, and I'm this busy television producer. I don't have time to come back in 2 weeks. But this doctor, she insisted upon it. So I went back in 2 weeks, and she's saying, okay, Tamika, you need to lose weight. You know, you're at risk for this, you're at risk for that, but, you know, everything is good. You don't have diabetes, your blood pressure is fine, your cholesterol is fine, you know, skin tests, all this stuff. I mean, she gave me the workup. And I said, great. And I grabbed my purse, and I'm lifting out the chair so I could head to work. I'll never forget this, even with my chemo brain, and I forget a lot. This is one of the things that I have never forgotten these past 10 years. She touched me by my knee so I couldn't get up, and she said, now let's talk about your Pap. And she says, you have carcinoma in situ. I didn't know what in situ meant, but I knew carcinoma meant cancer because my father, who was my everything, died the day before my 17th birthday of advanced colon cancer. I remember getting out of high school and taking him to get treatment. And there were other family members who've had cancer, so I knew what cancer looked like. I didn't think that I had cancer. You know, I didn't look gaunt. I had my hair. Nothing about me was moving slow. And I was 25. How could I have cancer? I didn't believe I had cancer. I thought, you know, this doctor, she doesn't know what she's talking about. You know, she's a quack. Let me go see another doctor. Saw another doctor, you have cancer. Went to see another doctor, you have cancer. When it was all said and done, I saw 10 doctors. 10 years now, as a 36-year-old woman, I can look back and I know that going to see all those doctors was because I was looking for a doctor to say, no, those doctors were wrong. You don't have cancer. You don't have to give up your womb. But the truth was, I did have cancer. And on June 14th, 2001, at 7:15 in the morning, at Johns Hopkins Hospital in Baltimore, Maryland, I was wheeled into the operating room, and I had everything removed that I thought made me a woman. And all I could think about was, you idiot, why did you miss your Pap? Why did you miss your Pap? And I kept thinking of how I would never be able to create life, how I would never be able to feel a baby kick inside me. Now, I know now that I can adopt at 36 years old, but when that choice was taken away from me at 25, it didn't register. I just knew that the girl with the perfect upbringing, the perfect family, and the perfect life wasn't so perfect anymore. And that may seem small-minded to some, but to someone who's had a life of so much, it was so devastatingly hard for me. After having my radical hysterectomy, it was followed by chemotherapy and radiation. In the end, I was diagnosed with stage 2B cervical cancer. I am thankful for my life because I know so many women who don't survive this cancer, even though it is preventable. I had great support. I had some of the best doctors, but everybody doesn't have that. I know women who are diagnosed with cervical cancer, and they don't know how they're going to get it treated. They don't know how they're going to get to an appointment. They don't know how they're going to be able to provide for their family. I know women, because sometimes cervical cancer whispers and you don't believe you have it, they don't get the treatment that's so desperately needed. We live in a time right now where cervical cancer is talked about all the time. This is the cancer that we know the cause, we have the tools to prevent it. But what I want you to know, that behind all the research, there are faces like mine, who have scars that remind them every day of what they went through, who have sexual dysfunction because of what they went through. But there are also faces that you will never see of those women who still die globally of cervical cancer. Like this woman who had, in May, I was very touched by her. She had 2 small children. She was a great mom. She had stage 4 cervical cancer, lived in Oregon. Her children will never remember her. Her life was taken because of cervical cancer. In this day and age, this should not happen. But women still do not have access to prevent cervical cancer. They need to be screened. They need to be treated. I thank you all for what you do, and I really ask that you go back to your homes and you remember my story. You remember Alyssa's story. You remember the story of Kristen, who just graduated from college and she died of cervical cancer. You remember the story of Mary Walker, who got out of a bad divorce and moved away with her family and started a better life for them. And just as the pieces were coming together and life was better for her, she got diagnosed with cervical cancer and died. Cancer is very, very, very personal for me. I'm a cancer survivor. I lost my dad, who I loved more than anything in this world, to colon cancer. I lost my mom almost 3 years ago, who was the gravy to my mashed potatoes, the cheese to my macaroni, the crust to my apple pie, to multiple myeloma. I hate cancer. I want there to be a world where cancer does not take away loved ones, where cancer doesn't leave you less than your whole. This is something that we can do right now with cervical cancer. We can make sure that women do not die of cervical cancer, that women do not lose their fertility, that if women are diagnosed with cervical cancer, they're treated at early stages. We can catch it at an early stage, and they keep their life. This is something that we can do. My name is Tamika Felder. I'm a 10-year cervical cancer survivor. I never thought I'd be a 10-year cervical cancer survivor. I never thought I'd be in a room sharing such an intimate, personal story with you. But we live in a world where women are ashamed because of that thing called HPV, and women don't want to share their stories. It's up to all of us to make sure that women are empowered, that women share their stories, that women be advocates to work right alongside you all so that we can end cervical cancer. I thank you for your time. I thank you for being here this morning. And let's make sure that we prevent cervical cancer and have a world where, where we won't need workshops like this. Thank you.
Well, thank you, Tamika, for sharing your story and sharing your message with us. I know that I speak for everybody here in saying that we listen not only as healthcare providers, but as patients, now, patients in the future, and family members. We're gathered here at this meeting as a community of laboratorians to exchange ideas and learn from each other, learn from patients like Tamika, and hope to hopefully find a common purpose. We each contribute to the care of patients in our own way. Some of us are clinical laboratory scientists, some of us are surgical pathologists or hematopathologists, some of us are clinical chemists, some of us are pathology assistants. We practice in the US and Canada, Europe, Asia, Australia, Africa, South America. Whatever we do and wherever we do it, we share common goals, but we face different challenges. And as we heard from President Clinton and Dr. Farmer, foremost among those challenges is reaching the patients who need our care. The goal of this session on global access to healthcare is to compare the ways in which patients' access to care in different health delivery systems affects our ability to reach them and help them. And we're going to use cervical cancer as an example. You will hear from an esteemed panel from around the world. You have already heard Tamika Felder's story, and she will participate in the panel, so you will hear more from her and get a chance to ask her questions yourself. As you know, Tamika is the founder of Tamika and Friends, an organization that has as its purpose raising awareness about cervical cancer and HPV through a network of cancer survivors and their friends. Other panelists include Dr. Deborah Graves, who is the Chief Executive Officer of the Royal College of Pathologists of Australasia. Dr. Graves is a physician who has held many roles in healthcare administration and been involved in quality assurance in Australia before and since coming to her role at RCPA. You have heard of Dr. Doreen Maziri in the discussion between Blair Holliday and President Clinton on Wednesday evening, and also she was mentioned several times by Dr. Farmer yesterday. Well, today you will get to hear from her directly. Doreen is an obstetrician and gynecologist who takes care of patients with HIV and cervical cancer in Botswana, and she is the country director for the Botswana UPenn Partnership. And then moderating the panel, we have Dr. Phil Castle. Dr. Castle is a well-known, because he has been an HPV researcher at the NIH, and speaks widely about this, and he is now the director of the ASCP Institute. So I will turn the panel and the discussion over to Dr. Phil Castle.
Thank you. So this is a call to arms. This is a call to action. The title of my opening remarks is Some Animals Are More Equal Than Others. Cervical cancer is a marker for global cancer health disparities. In the next slide, I always like to start off with a little bit of a cartoon. What fits in your busy schedule better? Exercising 1 hour a day or being dead 24 hours a day? Cervical cancer is a preventable disease, and I'm calling you all out right now to help us in this battle against a highly preventable disease that affects women primarily in their 30s and 40s, when they're still highly productive, leaders in their communities, keepers of the home. We need to address this question, and we need to address this disparity. Before I continue, I want to thank Dr. McKenna for helping to put this together. She doesn't get the ASCP Presidential Award for nothing. She's been a long-time member of ASCP, a distinguished member, putting in many, many hours, hard work, and brilliance. But I also want to recognize another person who's behind the scenes, who doesn't always get recognized. She works tirelessly, without complaint, and I want her to stand up. Andrea Bennett, please. So in the next slide, I show you a map of the cervical cancer incidence in the world. And I think you can see already what the problem is. It's not one color and it's not green. In the lower resource settings, women experience a 10-fold or greater burden of cervical cancer. And let me just say that these have to be underestimates because, as you know, there's no pathology in the lower resource settings. So we actually don't know how bad it is. These are estimates. In the next slide, I show you that there's the haves and have-nots. So on the right, on my right, your left, you see what happens in the developed world in terms of cancer, and on my left and your right, you see what happens in the less developed world, and you can see that all the cases happen on my left, your right, for cervical cancer. 86% or more of those cervical cancers happen in women who don't have access. This is a cancer of inequalities, and if you didn't get that from President Clinton and Dr. Farmer, let's make sure that you get it now. Just to put it in perspective, where do people die of cervical cancer is shown in the next slide. So this is to scale. So the bigger the geographical area, the more deaths due to cervical cancer. I think it's pretty clear where we need to go. But this is not a problem of over there. It's not just a problem of over there. It's not just a problem of other places that we often don't see or go. In the United States, there are hotspots, places like Appalachia, Mississippi Delta, the Central Valley of California, the border populations, and I can go on and on and on, of women who don't have access. They can't get to the clinics, they are uninsured. And I've had personal experiences of this. I've known Tamika for many years. She's a survivor. I had a colleague who recently died of cervical cancer just this summer. And what happened to her is she got diagnosed with cervical cancer and she could not get care. She went to major medical universities in California and could not get in the door. There's no reason for this. There's no excuse. But let me bring it back out and put it in perspective. So in the next slide, my last slide, if we sit around and do nothing, if we let inaction rule the day, we will get 40 to 50 million cases of cervical cancer over the next 50 years and 25 million deaths. That just blows my mind away. I mean, I don't even know where to go with that. So this is a call to arms. This is a call to action. We need all of you to come out and help us battle cervical cancer, an entirely preventable disease. So we have two great speakers who will will make it much more real for you. And Doreen and Deborah have come a long way, and I ask for your attention and listen closely to what they have to say. And I thank you for your attention.
Good morning, everyone. It's such a great pleasure for me to be here. And like Dr. Paul Farmer, this is my first time in Las Vegas. And I'd really like to thank the doctors John Tomaszewski, Blair Halliday, Phil Castle, Dr. Mark Stoller, Jeff Jacobs, and Dr. Barbara McKenna for inviting me to speak today, and really to acknowledge the two ladies who've made it possible for me to travel all the way here, Lucy Beck and Ms. Janine Harris. I just like to say thank you. So thank you very much for coming out this morning to come and listen to what we have to say. I don't know if this is working, the slides. Next slide, somebody? Okay. I don't see them over there.
Yeah, I don't know what's...
I'm going the wrong way. I'm pressing the green one. Okay, I don't think it's in here. Anyway, I'm sorry, I know you've had breakfast, but oh, we don't need to be there. Can we go back to my first slide, please? Okay, I know you've had breakfast, and I really didn't want to show you the West, so this is one of the best pictures that I've got. And if we go forward, this is, if I were shown that picture and I was asked to profile that woman, I would say she's probably in her 30s. She's probably HIV positive, been on HEART for a few years, and has been seen by several healthcare providers, and nobody dared look down below, either because they don't have the time, they don't have the speculum, or they just simply don't know that they have to look. And if she's one of those women who might have had a Pap smear, she might be still looking, waiting for her results, or she's got her results, they are abnormal, and she's waiting for further management. So let me tell you a little bit about my country. I come from Southern Africa. It's from a landlocked country. It's the size of Texas, 2 million people, and a democratic government. And we actually gained our independence in 1966. And there was a comment made by the British that our leaders were either very brave or very foolish. And that was a fair comment because we had nothing. We were rated one of the 17th, out amongst the 17th poorest countries in the world. We had one road, and it was 1 kilometer that was tarmacked. As luck would have it, in 1967, diamonds were developed. And again, due to the visionary leadership of our leaders, those were used for development. And I stand in front of you, ladies and gentlemen, as a product of those diamonds because I was educated with the diamond money. And within a generation, we have moved from being one of the poorest countries to being rated a middle-income country. Now, this is the closer map of the country. Most of those people live on the eastern part of the country because on the west is a desert. But services need to get to those people. Now what happened? I think somebody up there has a very funny sense of humor. They gave us diamonds, and 30 years later, they gave us HIV. And I'm sure you've seen this. And at the beginning of the epidemic, we were the highest prevalence in terms of HIV in the world. We now have the second highest. So, our president then, President Mogae, addressed the United Nations. And he said, we are threatened with extinction. People are dying in chillingly high numbers. It is a crisis of the first magnitude. And this is when he made the announcement that antiretroviral therapy will be made available to all the national citizens who needed them. And when he made this announcement, some people again thought such an ambitious plan can never work. And we heard again from Dr. Palmer and President Clinton about the lack of imagination in people. But he had to do something more than that. And that is when he negotiated prices. And we've heard again about the supply chain management and being able to negotiate in terms of volume, because there was a lot of volume that was going to be moved through the country. So he did that. But on top of that, and you have to understand this is within, even though we had diamonds, we still had finite resources. The budget for health was increased threefold. That is a lot of money. What also happened, mother-to-child programs had actually been at a pilot stage, and these were upscaled nationally. This is MASA. In my language, that means New Dawn, and this program was launched in 2002. To date, we've got more than 150,000 people on ARV. This is more than 94% of those people who need to be on ARV. What has happened is that this was actually the first African country that did this, and it really has led the field in terms of that. Of interest to you, you'll notice that the lab infrastructure throughout the country, with the help of partners like ASCP, with the help of PEPFAR and CDC, have been set up to do CD4 counts. The supply chain for ARVs is one of the best in the country. And this is really a clear example of what political will can do. Now, that is just the map to show you where all the, those labs are. This is in 2003 when President Bush visited our country, and this actually led to us being included in the PEPFAR budget. So, what happened? We've got diamond money, and that we think has been used in a very judicious way. What happened was that everybody had laser focus. The country, developmental partners, everybody. Everybody's thinking power was channeled to HIV. All the resources were channeled in terms of finances into HIV. And we set up some top-notch HIV services, but there were no linkages. And we've heard from President Clinton about how somebody will go to an HIV treatment center, but has to go somewhere else for mother-to-child transmission problems and go somewhere else for their NCDs. We set up great labs for CD4 counts, but they did not provide any other diagnostics. We have great supply in terms of ARV, but I can't even get the loops to be able to do my leaps for the patients that come through. And prior to this, we had large numbers of adults who were very productive dying. And what did that mean? It meant income to both families and to the nation dropped. It meant that we lost major numbers of people who've been skilled. That included the doctors, the nurses, the lab personnel, and everybody. And those who did not die of the HIV had burnout, or they just simply moved away. In fact, in my country, there's a saying, you're either infected with HIV or affected with HIV. So, what has been the consequences of our success? We've been able to keep people alive, but we're now having problems with other issues, the comorbid factors that are coming into the fore, the NCDs that we've heard about, the heart diseases, the diabetes, but more specifically, the cancers. And to me, cervical cancer is one of the issues that I worry about. We've seen this. I just want to quickly just show you in my country, and again, these are not very accurate because our cancer registries are not accurate. Lots more women die who've never actually reached hospital. But when we look at this limited data of 10 years, we find that the commonest female cancer is cervical cancer, followed by breast cancer. And if you looked at everybody, including the men, cervical cancer after Kaposi is the next common cancer. And the problem has been increasing over the years. And when you look and you divide it into HIV, you can see those red bars, the shift towards younger women of the HIV, and more of them are infected. So how do we screen for cervical cancer in my country? I had a chance to listen to some of the talks yesterday, and they're really talking about some far out sophisticated situation. But we don't have that luxury. We have the cytology, and I'll talk a little bit about that. And up till about 2 years ago, we didn't have anything else until our program started, where we provide visual inspection after acetic acid with enhanced digital imaging as a see and treat program. And prior to that program, there was no outpatient treatment. Everybody who had an abnormal Pap had colposcopy, no biopsies. They then were booked in for cone biopsy, which meant at least 3 days in hospital, loss of income. They're going to be done in OR under general anesthesia, lots of money. They're going to have a procedure that takes out a huge chunk of their cervix, and the chances of needing to go back to theater quite high because of bleeding. And then downstream, the problems of reproduction when they get there. So coming to cytology, I think all of you in this room will have no doubt that it works, and I'm sure Deborah Graves will tell us that. And we know it works when you have a very organized system. And it does require a very sophisticated infrastructure. It is very expensive. Whereas in my country, the way it's been done, it's really opportunistic. And what tends to happen, the same women get screened over and over again. So this is the barriers to my life, where I practice. This is the sort of barriers that we're looking at, where at every step, because it does require multiple visits. And remember, these are women. Some of them are looking after orphaned children from other relatives because of the HIV, or they simply have other pressing things to do. So coming backwards and forwards when they feel well in themselves is not a priority. So that is the issue. And what also happens if you have, like the picture of the woman I showed at the beginning of the talk, is that even if you have your Pap smear, it might take a long time to get those results, because your slide has to be transported, somebody has to read it, it has to come back, and you have to present yourself to be able to see. And optimistically, you might be able to get those results within 7 months, but in most cases, women who come to me have had an abnormal Pap smear. They've been waiting in the system for about 3 years. That is a long time. So, things that in the audience you might take for granted, these are the sort of things that I have to think about. And this is before even the woman gets a Pap smear that says it's abnormal and therefore you need something. I mean, the first thing is that she actually needs to be aware that she has to go and have a Pap smear. And when she gets there, there must be a provider who's able to provide that service. And sometimes the provider is available, and she knows what to do, but she simply does not have the slide or the cytofix to do that Pap. And we also assume that she's trained, and all of those things are in place. So where I am looking for an ideal screening tool which requires at the most 1 or 2 visits, and that is safe enough for the woman, that has got high enough sensitivity, and does not require an expensive and sophisticated infrastructure. And this is where visual inspection comes in, and we know that it works, we know it's acceptable for women, and even if a woman gets 1 VIA in her lifetime, it will reduce her chances of cervical cancer by more than 25%. And we know that it has limitations. And that is why we utilize other tools like the digital enhanced imaging that allows the provider, while she's seeing the woman, to be able to assess the picture and think about things. You can show the patient, and to a lot of patients, when you tell them your Pap smear is abnormal, it really is a very abstract thing. What exactly does that mean? What does my cervix look like? So with this image, we can show the woman what her cervix looks like and that little white thing that is her abnormality. We can keep them as a record. We can also provide continuous education development for the nurses who see these patients. Oh, it's great, I've got my slides now. So we were very fortunate to have PEPFAR funding, which came through in 2009, and with that we were able to set up 2 clinics, one a primary care clinic where it's nurse-led and they do visual inspection and EDI, and the LEAP clinic that I run where the woman with complicated lesions, huge lesions, come through and we do colposcopy. But we also, and you might be horrified sitting in the audience to hear that I do colp and treat. But again, we can talk about those in terms of the results that we've got. But again, we think this is the best that we can do for the women. So in the 2 years, we screened around 3,500 women, and we've treated more than 1,000 women. The majority of those women needed LEAP because these HIV patients, the lesions are really huge, and cryotherapy is just simply not going to do. So this is where we do our clinics. On the left there is the primary care clinic, and the MD Anderson type looking clinic there, that is my clinic where I do all my LEAPs. And this is a nurse who's has done VIA, and she's now got a digital camera, and she's taking a picture. And one of the problems, or one of the things that worries me was, are the nurses missing the lesions? Are they treating things that they shouldn't be treating? And again, the beauty of the images and record keeping is that we can, on a regular basis, go through all the pictures and just make sure that things are not being lost. I mean, that's a beautiful looking picture of the cervix. This is through a digital camera. It's actually better than my colposcopy. And this is a woman who's got an aceto-white lesion, and she was treated with cryotherapy. That's what a cryotherapy gun looks like, and it does not require any anesthesia. And that is a beautiful lesion if you're a pathologist or a gynecologist, but it's definitely not beautiful for the woman. It's got mosaicism, and you can see this with this digital camera. And this is the sort of woman who will be referred to me to have a LEAP. And as you can see, and this is my clinic, and it's standing room only. And at the back there, you can see we've got storage space. There's linen there just to make sure, because we have to hoard things. When they have things in pharmacy, I have to get as much as possible in case I go there the next time there isn't. So that's us doing LEAP. And of course, my friend, Dr. Kayembe, who is the lone pathologist who does everything from postmortems to looking at my LEAPs and Pap smears and everything. And he actually complained after we've been running for a few months to say, I have simply doubled his workload because of all the LEAP specimens that were coming through to him. I won't go through that. So what have we shown? We've shown that this can work in my country. We've been able to set up a system that can be rapidly scaled up. We've also set up an infrastructure that can assist in teaching, education, and research. But most importantly, and this has taken me several years, we've been able to generate data to take to the Ministry of Health and say, here we are. And finally, about a month ago, the permanent secretary in the Ministry of Health wrote a letter to us to say, yes, we think VIA can be an alternative screening tool, especially for women who are in the non-urban settings where they really do not have access to care. But as we heard from Dr. Farmer yesterday, decision doesn't necessarily end up with delivery. And that is really where the challenge starts. So how do we solve the bigger problem? We've heard about leveraging the assets that we've got. With HIV, we've been able to set up something magnificent from nothing. But we need to create linkages to care so that women do not fall through the cracks, that they can get their ARV, but also get a physical examination and get their screening. We need to start thinking creatively about combining disease management, cervical cancer with breast cancer screening. We need to think about overhauling the treatment options. Those machines that you saw are the 2 machines that exist in my country. We've got 1 cryotherapy gun and we've got 1 LEAP machine. And of course, and this is where you guys come in, we need to overhaul the whole pathology diagnostic systems. And that includes training, especially of the technicians. It includes the creative use of technology, telemedicine. Because if you can get somebody to prepare the slide, there's so many of you, surely we can find somebody who can help us as we're training other people. But we simply have to think about other options, planning for prevention, primary prevention, and again, advocacy, because the prices as they are right now are just simply not affordable. It's just been great these last few weeks with the United Nations talking about the NCDs. It's people like President Clinton and President Bush talking about NCDs, including breast cancer and cervical cancer. Global citizens like Dr. Pharma starting to talk about NCDs. And of course, people like you, the engagement of organizations like the ASCP, the WASPAM, to help us, because you've shown us that your organizational skills are unparalleled. And when it comes to delivery and implementation, we are going to need your assistance. And most importantly, it depends on us, the citizens of those countries, because without our commitment, nothing is going to happen. We are a peace-loving country, but I will tell you, when the resources are finite, this can happen, where there simply becomes a fight for resources, and it can end up in a dog-eat-dog situation. Ladies and gentlemen, I thank you for your attention.
Thanks, Doreen, for an inspirational speech. It was truly amazing. Just on behalf of the Royal College of Pathologists of Australasia, I'm really proud to be here today. Thank you very much to ASCP for inviting us to talk. Professor Tomaszewski and your team have been fantastic in relation to welcoming us here in your beautiful country. And I think people often refer to Australia as being the lucky country, and after hearing Doreen's talk, I think we are a very lucky country. So I'm going to be presenting a very different perspective in relation to cervical cytology, and I think we're probably quite proud as to where we've come with cervical cytology, but it's taken a lot of hard work and dedication from various clinicians throughout Australia. Before I get into that, though, I've actually been asked to actually give a bit of a streetscape of what the health system in Australia is like, because we are actually a very fortunate country and actually have a universal healthcare system. Australia's got a population of about 22 million people, so we're a very small country in comparison to the United States, and we cover a huge landmass, so most of our population's in the coastal areas of Australia. We are a Commonwealth of Australia, and we have 7 states and 2 territories. And the Commonwealth basically provides the states' governments quite a lot of money, probably about 60% of their funding, to provide care in public hospitals. So we have public hospitals provided by the states, and then we have a Medicare system provided by the Commonwealth government. Basically, everybody can get access to free healthcare in Australia at the point of delivery. We're very lucky from that point of view. If you're sick, you can actually attend emergency departments or public hospitals to actually get admitted and also have elective surgery. If you're actually needing to be seen in the community in relation to a general practice visit, seeing a specialist to actually get something worked up, having pathology tests done, radiology tests, they're actually covered by Medicare. On the whole, patients can actually get those free if they're actually more in the poor range, but sometimes there is a co-payment in relation to Medicare services of something of the order of 25 or 15% of the schedule. It's a good system. It does take a lot of money to actually operate, but we're actually quite happy with it. We do actually have restrictions. Obviously, there's waiting lists. That's one way that does control things. So if you actually need to get operations in relation to things like hip replacements and eye surgery, sometimes there are waits. And because of that, about 45% of people within Australia actually have private health insurance on top of the existing universal system. Everybody who pays tax actually has to pay a 1.5% Medicare levy, and there are tax incentives in relation to if you don't take out private health insurance when you're a certain level of income, you will actually have to pay more than the 1.5% levy. There's also tax incentives in relation to taking it out by actually getting a deduction in your premiums in relation to private health insurance, which is quite useful as well. All up, we spend about $100 billion a year on healthcare, and that's only about 9% of GDP. So it's quite low in comparison to the US, and also is pretty mid-range with other countries who provide these types of systems. Now to get on to cervical screening, I'd just like to acknowledge this slide is given to us by our Quality Assurance Program company, and they assure me it hasn't been photo-docked in any way, but I just think that the fact that there's a map of Australia with cytology sides, it's still a little bit strange actually, but I was very appreciative of it, so, but I think it was good. The cervical screening program in Australia commenced in 1991. And when it was introduced, they actually had a very intensive education program attached with it. And this was to educate both the public about the importance of having Pap tests, but also cytologists, cytopathologists, and GPs in relation to how to actually undertake the testing appropriately. And a lot of that education continues today. Pap testing are mainly done actually within general practices and covered by Medicare. About 80% of Pap testing is done within general practices, and then they are sent to private laboratories. There are some, probably about 20% of women's health centres and family planning clinics and sexual health clinics that do some of the Pap smears too. We have Medicare funding for the conventional smears only. That's purely what the program is based on, conventional Pap smears, and the rebate for that is about $19.60 in Australia. That barely covers costs, but it's something that is often considered to be a loss leader in some of the private pathology practices. Liquid-based cytology has been looked at extensively by our Medical Services Advisory Committee, but it's been found not to be cost-effective in relation to our program within Australia, so it is not used to date or funded by Medicare. However, about 20 to 30% of women do elect to actually have liquid-based cytology done on their smears in addition to the conventional smear, but they have to pay for that directly themselves. HPV testing per se is not actually funded for screening, but we do actually have it funded for test of cure following high-grade lesions. The National Cervical Screening Program is a shared program between the Commonwealth governments and the states. The state governments actually implement the actual program of rolling it out from a jurisdictional point of view, whereas the Commonwealth government tends to provide overall policy coordination, national data collection, quality monitoring and evaluation. The actual register itself will actually record all cervical cytology, histology and HPV test results. Pap smears are recommended every 2 years in Australia, which is sometimes some people have a 3-year program, but we're currently still at a 2-year, but that is being considered at the present time. The first Pap is usually between 18 to 20 years of age or 2 years after first having sex and continues until at least 70. Women with abnormal smears are actually managed in accordance with our National Health and Medical Research Council guidelines, and I won't go into that in any detail, but they're fairly stringent guidelines in relation to evidence-based medicine. The registry is an opt-out system. There was a lot of controversy when it was set up in relation to privacy issues as to whether it should be opt-in or opt-out, and finally it is now an opt-out system, and it's pleasing to note that there's only about 1% of women who elect to opt out of the system. The pathology laboratories have to routinely provide the Pap test results to the registry, and that's an ongoing issue in relation to the laboratories. One of the great successes I think that's helped contribute to the program is that in Australia, any laboratory that actually receives funding, Medicare funding for pathology tests, has to be accredited via the NATA, which is the National Association of Testing Authorities, RCPA. It's a joint program with the College of Pathologists accreditation program. And while that's based on the ISO 15189 standard, we have a standard set up by a National Pathology Advisory Council, that are actually specific for Australia. And one of those standards includes the requirement to actually have performance measures in relation to your cervical screening program. And they've been incredibly important in actually driving the success of the program and making sure the quality of it improves all the time. In fact, the data that has come out of the actual, the performance standard data has actually allowed the program to measure the sensitivity and the PPV values of the program. And it's pleasing to note that the sensitivity for high-grade lesions is about 78%, which is a lot higher than the often quoted 50 to 60% in other countries, and a PPV of 78%. Recent stats in relation to the outcome of the program, we have a 2-year participation rate of about 61% and a 3-year participation rate of 74%. And I think that highlights some of the issues that we do have challenges in our program. We're not perfect by any stretch of the imagination. And there are large sections of our community that are not getting screened. And that's particularly Aboriginal and Torres Strait Islander women who often live in remote communities, which is a very challenging issue. And a lot of our migrant women from non-English speaking backgrounds are very reticent to actually have this Pap screen test done. So they're the challenging areas, I think, in relation to targeting women and also getting more young women actually on in relation to the screening program. Pleasingly, however, since 1991, the number of cervical cancer cases have actually decreased. Back in 1991, there was 13.2 new cancers per 100,000, and in 2007, that had reduced to 6.9. And even more pleasingly, the mortality rate had gone from 3.9 per 100,000 down to 1.9. And it's something that I think is very exciting for all our colleagues. Finally, just to get onto HPV and cervical screening, we've actually introduced the HPV vaccination program in Australia in 2007 for all school-age girls between 12 and 13 years of age, and there was a catch-up program available for women up to 26 years of all. We were one of the first countries to do so, but not surprisingly, I suppose, in some ways, because Professor Ian Fraser, who was very active in the HPV identification and relationship with cervical cytology, is actually one of the fellows of our college. So we're very proud of him, and he was very instrumental in pushing these initiatives in Australia in relation to getting the vaccination program introduced. The vaccine we use is the quadrivalent vaccine, and it's got the subtypes of 16, 18, 6 and 11. We're at a crossroads now, though, and there's a lot of discussion in Australia at the moment as to what we should be doing about HPV for screening and whether that should be something that should be looked at. I was talking to Dr. Annabelle Farnsworth, who's a very eminent cytopathologist in Australia and is one of our leading pathologists in this area. And she said that the debate at the moment relates to the fact that because we have such a high sensitivity in relation to our conventional spheres, she feels that before we actually make major changes to the program, a major study needs to be looked at. Because of the cost of HPV testing and also the low PPV value, we're not too certain whether it's going to be the way for Australia, and that's going to be a challenge, I think, over the next few years. We know our Commonwealth Government is wanting to review our program, and we'll be looking at it, but we hope that they will take our advice and be able to do a study in relation to it and look at the evidence in relation to the issues. So that's it from me.
So I'd like to invite Dr. Tomaszewski and Tamika to come up, and we will chat a bit before we end the session. So Tamika, since you've had the most time to relax, I'm gonna nail you first here. Okay. Could you talk a little bit about the barriers in the United States? I mean, obviously, we have very low rates overall in the United States, but as I pointed out on the map, there are access issues to special populations, and I think to make it more real, talk about some of those barriers. And it's not just insurance. I mean, I know that's a big part of it, but...
No, it's not just insurance. I can also say, as an overweight woman, I had body issues, so that was another reason why I wasn't actively going in to get a Pap test. And a Pap test isn't fun. I don't think there's any woman who just says, yeah, I like getting a Pap test, I'm gonna go. You know, that just doesn't happen. But there's lack of education. I can't tell you how many women who call our hotline, they're having issues, and I ask them, when is the last time you had a Pap test? And I've heard so many times, especially from women of color, I had a Pap test when my last child was born. Then I asked, well, how old is your child? 15, 20. And it's just hard for me to really get them to understand, like, no, you still have to go in. But there's also, outside of the lack insurance, so you have communities that aren't talking about it. You have the stereotype for people who do know what they're getting a Pap smear for about HPV or cervical cancer and thinking that it's something that can't happen to them, or they just don't want to know. Sometimes knowing that something may be wrong, but I'm not having any issues, so I'm not going to go and get it done.
Great, thank you. So Doreen, I'd like you to bring it down to the woman level in Botswana, because many of us have never been there, many of us will never be there. What's it like? Like, what's the hurdles in getting screening? Is it even on their radar? I mean, I think we need to hear what it's like on the ground in Botswana.
That's a great question, Phil. And well, let me just take it from another end and say I'm sitting down with a woman, and this woman, probably when she's HIV positive, like I said, and when she first accessed the ARVs, she was probably on a stretcher with the CD4 count in the low 20s or 30s, really very sick. And this woman has been accessing care for many, many years and comes into contact with health professionals. And she comes to me for something else, and I decide, since she's here, I'm going to have a look down below. And you look, and she's actually got a huge cancer. And this is the first time this woman hears about cervical cancer. This is the first time she hears that this could have been prevented. And it is just, I cannot express enough the shock on this woman's face when you tell her. She's 30, she's probably got small children, probably low income. And so yes, there is lack of education. I simply do not know that there is something that I need to go out and be tested for. We've had messages about HIV on the radio, on the newspaper, on television. That's why people go in and get tested. And especially after the ARV became available, because people knew there's something that could be done, whereas before it was hopeless. And we simply know that with cervical cancer, that is true. Like Tamika said, no woman should be dying out from cervical cancer. And this really is truly a disease of inequity.
So, Deborah, we talked a little bit before. Talk a little bit about cancer, cervical cancer in Southeast Asia, and also talk a little bit about cancers that occur in Australia. You have a great program, but cancer still occurs, and who does it occur in? Who gets cervical cancer in Australia?
Thanks, Phil. Look, I think mainly, as I say, there is a high incidence of cancer in the Aboriginal community, and also in people who are not getting Pap tested at an early age. I think that's where our major sources of cancer are, and the migrant women. Australia does actually have a large migrant population, which is great and gives us great diversity. But the challenges in relation to, from an English language point of view, of actually educating them to get Pap smears is very difficult. And then there's often a cultural barrier of not wanting to have a Pap smear as well, which causes those problems. In Southeast Asia, we're starting to look at more extensively about pathology services in places like Fiji, Vanuatu, Papua New Guinea and East Timor, which are close neighbours of ours. And they're very, very limited. I mean, Fiji has about 2 pathologists, I think, and the level of there's no organised Pap screening testing there. And Timor is a new country, and the services just aren't there. So there's a lot of challenges in those parts of the country where, while we've got a great program, there's nothing happening in those areas. New Zealand's our closer neighbour. They do have an extensive program, but they have a similar problem with their Maori population, who have a very, very high incidence of cervical cancer. So I think in our area we've actually got huge challenges, and our college is wanting to extend out into those regions to see what we can actually assist and train people up to do the things.
So, Dr. Tomaszewski, as the president of the ASCP for a few more hours, and then past president, and one of our
6,
and our fearless leader, talk a little bit about the ASCP's commitment to eradicating cervical cancer worldwide and what role we should be playing.
Absolutely. So we see this as a systems problem, as President Clinton was saying, and we really hope to be able to impact an improvement of systems available in developing countries. We're very taken with the idea of creating an interface between organizations that are out there now, partners and ASCP, with a lab interface could be a tremendous arrangement for organizing the infrastructure development that we need to work on. It's very interesting to me that everybody talked about personnel's lack of pathologists, lack of technicians, and we talk about the same thing in America. We don't have trained personnel. It comes down to workforce shortage. And so I think an important lever will be to enhance training, however we need to do that, training such that it's self-sustaining. Interventions have to be self-sustaining because resources have to be created anew and be able to replenish themselves. So we're really looking to focus on teachers, creation of healthcare workforce, supply chain, and the technical logistics that we need to get in countries.
So I think we have the ability for the audience to ask questions, maybe, I hope, or not. Yes, so I'm going to open it up to the audience. Sorry, I have to shield the light. I can't see anything. I'll go blind. Please introduce yourself so that we get to know you and address your question to one of the panelists, please.
I want to thank you for your great presentation. My name's Lori, and I'm a resident. And my question is directed towards Dr. Ramagola Masar. I want to also say what wonderful work you're doing. I know presenting this to pathologists is a little problematic because what you're describing does not have a tissue diagnosis. But I think especially in the setting of HIV, there's almost nothing else you can do for some of these patients with the resources that you have. But if a woman is not HIV positive, on the other hand, it might be risky, increasing her risk of HIV. Also, my question for you is, have you seen an increased rate of preterm delivery among women that have been treated in this way from cervical incompetence? And what has the pathology shown from looking at these? Has there been quite a lot of false negatives?
Thank you very much. It's a great question. And so coming back to what pathology shows, so certainly patients who have cryotherapy, you do not have tissue diagnosis. But women who do have LEEPs will have tissue diagnosis. I had all those slides, but I decided I'm not going to put them in. And certainly over the about 1,000 plus LEEPs that we've done, we did an analysis of about 340 results that had come back. And yes, you're right, there will be false negatives. Out of those 340, we had about 9 that were chronic cervicitis. And we had a few that were CIN1, but the vast majority were CIN2, CIN3, and we even had about 6 microinvasive diseases when these women went forward and had hysterectomy. I mean, the CIN2, CIN3 was close to 300. So quite significant in terms of that. But remember, I have done colposcopy for a very, very long time. And again, that is something that you have to think about because as you train people, they're not going to have had the experience that you have. So that certainly is a fair comment. But the other question is that if I'm over-treating the women, am I putting them at unnecessary harm? And, what we do is LEEP. We take about 0.5 to about 1 centimeter. And we do know from the literature that the risks of premature rupture of membranes and premature labor is a lot less than if these women, because the alternative, and certainly where I am, would have been they would have had a cone biopsy, which takes about 2 centimeters with even more dramatic effects. So I think we've only been in the program 2 years, so we haven't seen that, but we can extrapolate. HIV negative women, I'm funded by PEPFAR, which means dictates that I look after HIV positive women, but certainly those also need to be looked after. And when we think about scaling up, we need to be inclusive in terms of those women as well. Thank you.
John.
I'd just like to make a comment on there and draw a connection. We talked about 21st century diagnostics, and Doreen, you're actually sitting on a tremendous database of cervical colposcopy images. You're an expert in interpreting these, and you're very good at sort of microstaging from the appearance of the image. But you know, there's a possibility to actually have enabling technology for computer-assisted support of your analysis of those images, and actually to deliver that globally. And this is a sort of, from the most general techniques of gross examination, visual inspection, to the most elegant techniques of sort of computer modeling. You can put those things together and actually draw these connections across a wide sphere. So I sort of recommend to the residents and the trainees that there's a huge new piece of the world that will allow you to make your gross examination, your colposcopic examination, a big piece of data.
Yes, please. One more question.
Hello, my name is Rajan Devar. I'm a hematopathologist at Beth Israel Deaconess Medical Center in Boston. But somehow I got involved in this very intense cervical cancer screening program in South India, the country of my birth. The problem that we face there is somewhat in a cultural context. We have resources, and cost is not an issue anymore. In these HPV-based screening strategies, we are having a problem in telling the patient that HPV is a sexually transmitted disease. It's a big problem. It's a cultural taboo, and women just do not want to get tested for a sexual transmitted disease. Sometimes we see patients who say that, oh God, doctor, you did a great job preventing my cervical cancer, but my husband left me because I was diagnosed with a sexually transmitted disease. I wanted to know how other countries are handling this issue, or if this is a problem at all in other countries.
It's a problem everywhere. I can honestly say I never thought that I would be in a room talking about this because I was ashamed. I remember being at a cancer retreat for women, and someone mistakenly said that I had ovarian cancer. I didn't correct her, and this was early on. This was about 2 years after my diagnosis. I didn't correct her because I thought about the shame and how I would be judged, even though I went through surgery, radiation, and chemotherapy like anyone else with cancer. But because of those 3 letters, that word that I couldn't even pronounce when I was first diagnosed, human papillomavirus, I was ashamed and embarrassed. And it ate away at me. It was like having a secret that just ate away at me. I got on a message board, found some woman that was in Europe somewhere. She was embarrassed. We started chatting. Long story short, that night I said I would never be ashamed of what happened to me. And that's what I do. I try to encourage women, really in the US, slowly doing it globally, just when people find out about us, and we've had people from Africa contact us and other places, and I'm so what you're doing in Australia. Yes, I think Australia is really going to really change that already, because obviously the women go out there and the government is helping getting the screening. But it is a major problem. And it starts with the medical community also. We have to stop with the fear and terror. HPV is very common, and I don't have a perfect answer. But it's not just in India or other places. It's a worldwide problem. And that's why a lot of cervical cancer survivors and people with HPV don't speak out, because they're ashamed and embarrassed.
I want to thank everybody for attending this morning. I wish we could keep this conversation, because there's a lot to be said for another hour, 2 hours, or 3 hours. But there are lots of other sessions, so we're going to close down for now. But please come up and talk to our speakers. They're amazing people. I've known Tamika for 6 years and is a personal friend. And I have known Doreen almost that long, and I have a new friend in Deborah, so please come up, talk to them, ask your questions. They're wonderful people. Thank you.
Well done. Thank you very much. I do need your card.
Absolutely.
Thank you, Tamika. Thank you.
É melhor ser alegre que ser triste. Alegria é a melhor coisa que existe. É assim como a luz no coração. Mas pra fazer um santo